Good morning, everybody. I'm Dr. Lim Jit Fong. I am the president of the Society for Continence Singapore. I want to welcome all of you, and I want to thank all of you for taking your time out from a long Good Friday weekend in Singapore to join us today to learn more about the Clean Movement campaign we have. And today's topics will revolve around bowel dysfunction and bowel control. Next slide, please. So the Society for Continence, next slide, please. Yes, thank you. Society for Continence Singapore started in 1991 from the dedicated work of a group of doctors, nurses, and rehabilitation specialists. So we are now 31 years old. Our vision is to provide knowledge and support for all sufferers of incontinence in Singapore. And in incontinence, we talk about urinary incontinence as well as bowel incontinence. And the third one that we don't usually mention much is the loss of the loss of vaginal support in some patients with vaginal prolapse. Our mission is to develop strategies, organize programs, and create awareness of incontinence. We work with the government organizations as well as non-government organizations to try and find ways to improve support for incontinent patients. And we use this opportunity like today to make continence awareness and care a multidisciplinary task for all our healthcare organizations. Next slide, please. So the Society for Continence, I'm happy to tell you, is now an IPC status charity, an institution of a public character. So we are registered with the National Council of Social Services. Our aim is to restore the dignity of incontinence sufferers in Singapore, and I hope that you will all enjoy and learn from the webinar today. Next slide, please. So the next slide is really the program for today. And we have 4 esteemed and wonderful speakers today to share with us their specialty knowledge on bowel control. The first is Dr. Surenda Mantoo. He's a senior consultant from the Department of Surgery in Puat Hospital, and he specializes in bowel control and colorectal surgery in Puat Hospital. He's talking about managing bowel dysfunction. Next, we have Miss Bridget Marr. She is a member of the Society of the Nutritionists and Dietitians of Singapore. Rather Singapore Nutritionists and Dietetics Association, of SNDA, and she's going to tell us about how we can optimize our gut health and bowel function through good diet. We have Miss Belinda Ooi, a senior physiotherapist from Puat Hospital as well, to help to teach you how you can improve and control and prevent bowel dysfunction through exercises. There will be a short description of a new pelvic floor exercise machine by Dr. Fiona Wu, who specializes in urinary control and pelvic control. And we will lastly end up with some Q&A sessions with all of you. Now, it's important that I hope that all of you can stay to the end, because at the end of our question and answer session, we will be having a 3-question lucky draw. The first 10 correct answers to the questions will win a prize. I will leave it to the end before we tell you what the prize is. Okay, and with that, I hand it over to Dr. Surenda Mantoo to start your talk on managing bowel dysfunction.
Hi, good morning, everyone. I hope you can see my slides. First of all, thank you, SFCS and Dr. Lim, for inviting me for this talk. I am Dr. Surenda Mantoo from Puat Hospital, and I'm a colorectal surgeon. And I'll be starting this webinar on topic of managing bowel dysfunction with a focus on management of fecal incontinence. I'll be talking about what is fecal incontinence, also commonly known as bowel incontinence. What are the causes of fecal incontinence? That is, why do we get it? More importantly, I'll be discussing some of the common myths and facts related to fecal incontinence, how we can control and even manage fecal incontinence, And at the end, there will be a take-home message. Fecal incontinence is any involuntary passage of gas, liquid, and or stools. However, the problem is that different people mean fecal incontinence differently. Some call it diarrhea, some call it, bowel wetting, some call it it's not a medical problem. So there is a lot of misconceptions or myths about fecal incontinence or bowel incontinence. In simple terms, no or minimal control or passage of stools can be called as fecal or bowel incontinence. Now, there are multiple causes which can cause fecal incontinence. And to understand them, we need to look at this simple diagram, which shows the colon and the rectum. And the zoomed in part is the rectum and the anal canal, which is mainly responsible for maintaining continence, and the structures around it, like the muscles, which control our continence, known as internal and external sphincters, and the nerves supplying these muscles are responsible for maintaining continence in any individual. So simply any problem with either rectum or anal canal or the muscles surrounding the anal canal and the lower rectum, or even any problem with the nerves can lead to fecal incontinence. One of the commonest causes of fecal incontinence we all know is childbirth. So practically every female is at risk of developing fecal incontinence. If you look at a simple line diagram on the left-hand side of the screen, you can see the vagina and the anus is very close to it, just behind it, and the baby comes out through the vagina. Sometimes to facilitate the delivery, the gynecologist may need to do an incision of the vagina to facilitate the delivery of the child. And this procedure, what we call as episiotomy, if it is not done properly, or if it is done a bit more extensively to facilitate the delivery, it is one of the commonest causes of fecal incontinence at a later stage in the life of a female. I'll be discussing some of the common myths about fecal incontinence, and I will try to tell you what are the actual facts related to fecal incontinence. And some of the common myths which you might be knowing or you may not be knowing are that fecal incontinence is not a common problem. And people may be saying, and there are many patients who actually tell me that I'm not incontinent, I just have diarrhea. Some people think that incontinence is a normal part of aging. And some people even think that incontinence is a minor inconvenience and it does not affect the quality of life, so why bother about it? And more importantly, there is still a belief, not only among the general public, but among many healthcare professionals, that fecal incontinence cannot be treated. So my job today will be to tell you what are the facts about managing fecal incontinence. Starting with myth number one, leakage of feces is not a common problem. Now, it is a myth because fecal incontinence suffers from what is called an iceberg problem. Now, iceberg is a block of ice which floats on water, and what we can see only the part which floats above the water. But actually, the problem is much more under the water. So similarly, fecal incontinence, which we can see, we think that it is not a common problem, but actually it is a much bigger problem than we can see. Now, in terms of numbers, on an average, about 2 to 5% of general population is believed to be suffering from fecal incontinence. And when we get older, about 10% of people more than 65 years of age can suffer from fecal incontinence. And it's one of the commonest problems in people who are admitted to nursing homes. We don't have much data from Singapore and rest of the Asia, but we believe that on an average, about 2 to 5% of general population in Singapore will be suffering from fecal incontinence as well. The reason for this is that one of the most common reasons for admitting people to nursing homes is fecal incontinence, because people find it hard to manage, and they think that the best solution is to admit the person to a nursing home and let the healthcare professionals take care of the person. It is one of the problems which has been underreported as well. As a result, most of the people who do have fecal incontinence suffer in silence. Now, if we look at Singapore, 5% of 5 million population will easily mean that we have about 250,000 people who may be suffering from fecal incontinence. So it's not a small problem, it's quite a big problem, but unfortunately we cannot see the real problem of fecal incontinence or bowel incontinence in our society. And we know that this problem is going to grow much bigger because we are an aging society. And as if you can see the brown bar on the right-hand side of this slide, you can see that people who will be aged 65 and more will increase by next 20 to 30 years. So similarly, the problem of fecal incontinence will get bigger and bigger. Now, what are the reasons for this? Why can't we see fecal incontinence as a big problem? Why do we still believe that it is not a common problem? And there are many reasons for that. One of the most important reasons that there are challenges faced by the patient. Most of the patients are actually embarrassed to talk about fecal incontinence. It could be related to the stigma, which is attached to leakage of feces, the smell, and other issues. There is also a lack of awareness, not only among the patients, but also many healthcare professionals about fecal incontinence. And some people find it that it's all right to live with incontinence without doing anything about it. And as I said earlier, that there is still a strong belief that there is no treatment for fecal incontinence. Coming to myth number 2, which is a very common problem which I face in my clinics, that most of the patients who actually have fecal incontinence will tell me that, doctor, I am not incontinent, but I just have diarrhea. But it's not normal to have a diarrhea all the time. So the fact is that any uncontrolled loss of feces, that means when you cannot control it, it is fecal incontinence. The problem is that most of the patients find difficult to talk about it, and it gets lost in translation. In a study, it was found that more than 70% of patients who had fecal incontinence did not voluntarily talk about it to their physicians. That means they did not know how to say about it to their doctors and seek help for it. And similarly, when physicians did not ask, more than 75% of patients do not actually report it. So there is a barrier between the patients and the healthcare professionals about fecal incontinence. Patients don't talk and physicians don't ask. Now, if you ask a group of people, what do you mean by fecal incontinence? They will say multiple words and multiple definitions about it. Some may talk about bowel movement, problems with diarrhea, hygiene, but actually many people do not know what is the actual meaning of fecal incontinence. So we need to break down these barriers. We need to break down these barriers so that we can help these patients. And this can happen only when we increase awareness about this medical condition. And I'm very happy that webinars like today are a step in this direction. We need to educate public at large, and more importantly, we need to educate many more healthcare professionals about this condition so that they can identify or they can recognize this problem in the society and direct these patients to the right care so that these patients can be helped. We need to support these patients, and we need to train the healthcare professionals also how to manage these patients and how to manage these medical conditions. And we also need to find more newer treatment modalities so that the treatment becomes easier and more effective for these patients. Myth number 3, that many people believe that incontinence is a normal part of aging, especially when we are an aging society. We believe that, oh, it can happen in old age, so it's not a medical problem. The person can continue to live with it without any problems. But the fact is that fecal incontinence is normal only in infancy. So any uncontrolled passage of feces is fecal incontinence, and it is abnormal even in old age. Age is a contributing factor, and it is one of the commonest factors for fecal incontinence. But fecal incontinence is common in other people also. Like, it's very common post-childbirth in menopausal women. It is common after any surgery in the pelvic area around the rectum and the anal canal, like hysterectomies, prostate treatments, or even anal canal and rectal surgeries. So there are many people other than older age people who can suffer from fecal incontinence. Myth 4 is fecal incontinence is a minor inconvenience and it does not affect the quality of life. Many people believe that, oh, okay, it is there, I can't do much about it, so I can live with it, and it will not affect my life. But the fact is that if you really ask a patient about fecal incontinence, they will tell you that their whole life revolves around the fecal incontinence. Now you can imagine simple pleasures of life like watching a movie is difficult for these patients because they fear about smell. They think that if they are in a cinema hall and they leak, there may be smell and people will not like it. Simple pleasures like swimming is a big problem. And so much so that these patients almost self-isolate and do not go around or go out of their confines. Because whenever they want to go out, the only thing which comes to their mind, will there be a toilet around? Can I go safely? Will I be having a leak? So much so, if you look at this picture, the only road signs they look is bathrooms, 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 and not really going to enjoy a place they want to go to. So there are multiple negative impacts of fecal incontinence, leading to poor self-image, isolation, anxiety, loss of sexual life, loss of financial freedom, because many of these patients actually do not take any jobs because they are more worried about fecal incontinence. And as rightly said, that fecal incontinence may not kill a person, but it can take the life out of the person. Now, the last myth, that fecal incontinence cannot be treated. It's just like any other medical conditions, which can be treated in a majority and controlled in almost all patients. And we treat it just like any other medical condition. We identify the problem, which is the most important step in this, because many of the patients are not referred to the appropriate or the right help so that they can be managed more effectively. After identification, we check how severe or how bad is the fecal incontinence with some simple tests, which I will show you in my further slides. And when possible, these patients should be referred to an appropriate specialist who can use some treatment options, mainly medical and sometimes surgical options for managing fecal incontinence. Now, when a patient is referred to a specialist, we assess the severity and do some tests. And we almost always start with conservative or the medical treatment and with some exercises, which is also known as biofeedback. And Miss Belinda will be talking more about it in the next or the following lecture. And we do consider surgical options in select patients. And there is always a multidisciplinary management along with patient support groups who are involved in taking care of these patients. Now, in simple terms, how to assess the severity, we have simple scoring systems like shown here. We want to know how often is the fecal incontinence and how bad, and then we give some numbers. If you look at the scoring card, 0 is a perfect control over bowel continence, and 20 is the worst control. And similarly, we have manometries which check the pressures of the anal canal and can tell us about whether the muscles are functioning well or not. And we can also even do an ultrasound, which also tells us about the integrity of the muscles. That means whether the muscles are intact, whether there's any breakdown of the muscles, either due to any surgical procedures or any other issues. And in most of the patients, we do start with medical therapy, which mainly revolves around the antidiarrheal medicines to reduce the stool frequency so that the people can go out without the fear of leakage. But most of the times, medical therapy can improve only minor incontinence, and we may need to do further tests and see whether the person is suitable for any surgical interventions or not. Biofeedback is very important. I will not go into the details of the biofeedback. It's simply an exercise program which a person is tailored to a person and practiced over a longer period of time to allow a better control of continence for both urinary as well as the bowel continence. For surgical management, just to give you an idea, we have multiple options, and I call them 5 R's. We can repair if there's any defect in the sphincters. We can re-innervate with some newer modalities, which are like pacemakers, like sacral nerve stimulation, posterior tibial nerve stimulation. We can reinforce the anus with some bulking agents and other sphincter devices. We can replace the sphincters if they're very badly damaged, and very rarely we may have to divert the fecal stream if nothing more can be done. So there are multiple options for managing fecal incontinence in different patients. Now, this is the most important message from this talk, that patients who suffer from fecal incontinence are not alone. We have a team of specialists or team of healthcare professionals who take care of these patients, with patient being at the center of this multidisciplinary team. There are multiple people involved. As you can see the speakers here, they will be talking about different aspects of managing fecal incontinence. But just to impress that, these patients are managed in a multidisciplinary team, and a lot of attention is taken to know the patient's real problems and how to manage them. Now, coming to my last slide, we have so far known what are the myths and what are the facts. The myth is that it is a normal part of aging, and the fact is that it is abnormal at any age other than infancy. Fecal incontinence is a definite medical issue which can be treated like any other medical condition. Fecal incontinence and diarrhea are not the same thing. They mean different. Diarrhea is a short-term problem, but fecal incontinence is a long-term problem and needs to be treated like a medical condition. We have multiple options and a multidisciplinary team to treat these patients, and fecal incontinence can be controlled and cured in a majority of the patients. And fecal incontinence is not a minor inconvenience. It takes the life out of a person. So let's all spread awareness about this medical condition and identify these patients, and we can help them together. Thank you very much, and I'll be happy to take any questions at the end of these lectures, and I will hand over back to Dr. Lim.
Thank you, Surendra, for your wonderful talk. And I'm sure that the audience has learned a lot about the facts and myths about bowel control and how we can therefore take better control of our own health. The next speaker is Ms. Bridget Marr. She's going to share with us about how we can improve our gut health and our bowel control through a good diet.
Good morning, everyone. I'm just going to start the slideshow. Yeah, thank you very much for inviting me to speak today. Thank you to SFCS. I'm here on behalf of Singapore, the Singapore Nutrition and Dietetic Association. I've worked in digestive health for nearly 20 years now, both in the UK, and Singapore has been home for the last 8 years. So without further ado, we'll move on to my talk. So I'd like to cover today the function of fiber in the diet and sort of how to get the balance right, possible triggers of fecal incontinence, and this will be different for different people. What might improve bowel function, some tips to try and help diet-wise, possibly, using a food and symptom diary and how that might help identify triggers, and the different types of fiber and fiber supplements that might be worth a try as well. So if we think about sort of what happens when we eat food from when we pass a bowel motion at the other end, there's an awful lot going on, and our gut does an incredible job. I just like to focus on the function of the large intestine, which is sort of where the feces is made. And it's about 1.5 meters long, and food will pass into the large intestine in quite a sort of semi-solid liquid state. And there's around 1.5 liters entering the large intestine per day. And then at the end, when we pass out a bowel movement, there's only around 100 milliliters of water on average in that bowel movement per day, with an ideal bowel movement. So the large intestine has got to do, make sure that the function is sort of reabsorbing the water and the salts. The gut microbes have got to do their job as well. So if we think about the Bristol stool chart, I'm sure many of you have seen this with your doctors, with your multidisciplinary team. We're trying to aim for a type 3 or type 4 on the Bristol stool chart, really, to facilitate sort of the type of bowel movement that will be easy to pass. It's not too hard, not too loose. It's not sort of constipated, type 1, type 2, which can aggravate fecal incontinence. And it's not too liquid either, which can also be associated with more likelihood of fecal incontinence happening. So we're looking for around a type 3 or 4, and what type of foods will help achieve that. So dietary fiber, foods high in fiber, are extremely important in our diet. We know that plant foods have a diversity of fibers, that they provide a rich range of different fibers. We can divide fiber into sort of 2 different categories, which is insoluble, which is the sort of the tough stalks, hard stalks, the stringy bits, the pith, the tough waxy skins, seeds, pips are going to give a fair amount of insoluble fiber. So this isn't soluble, it doesn't break down to form gels. The other type is the soluble fiber, which gets broken down and forms, our gut microbes love it. They help feed them and keep the population of gut bacteria healthy in our large intestine. And they tend to get broken down to a gel and get fermented by the gut bacteria, and they can really help with the stool consistency of keeping the stool soft. The insoluble more works by bulking out stools, but the soluble has excellent water holding properties. So that's what we're looking for, is a balance between the two, and we'll be looking into a bit more of the different types later on. So what we might find as well in fecal incontinence is that if someone's having a diet which is too high on the insoluble fiber, so too much of those tough skins and seeds and pips and sort of the indigestible part of fiber, that might increase what we call transit time. So it will make food pass through the gut quicker, which might not be what you want with if you're suffering with fecal incontinence. So it might be more of a balance and trying to look for more soluble fiber, taking note of what type of foods aggravate, more likely to aggravate. So just to highlight the overall benefits, you know, they keep our digestive system healthy. They influence the frequency that we open our bowels and the consistency and the weight of the stools as well. Also, many other health benefits. So they can help lower cholesterol levels, especially the soluble fiber that we find in oats and beans. They can also have effect with stabilizing blood glucose, because foods high in fiber are going to be absorbed a little bit more slowly than those highly refined foods, carbohydrate foods. And we know there's a link with reducing certain conditions such as heart disease and some cancers such as colorectal cancer. And our gut microbes in our large intestine, which there are trillions, and the current thinking is that it's not just us, that we're actually an ecosystem living in balance with our gut microbes. They love dietary fiber. They love a diversity of plant foods. So keeping them well fed is really important, but also being mindful of getting the balance right with fecal incontinence and finding out what suits you. But we know conversely that a diet extremely high or really just predominant in very refined foods, highly processed, ultra processed foods with not much fiber, not including much fruit and vegetables and whole grains, that is the type of diet that doesn't help our gut microbes. It results in what we call dysbiosis. So where we don't get the right balance of the healthy gut microbes, and linked with now many health conditions. And even brain health. So we know that this diversity of plant foods is a good thing to aim for. So now I'd like to just go through some possible triggers for fecal incontinence, and just to be aware that this isn't sort of me suggesting that it's an all or nothing thing, that caffeine is something that, or any of these groups of foods are foods that we need to completely avoid, but it's worth noting whether it's a trigger. And there will be a dose effect. So the bigger the dose, the greater the effect if you are sensitive to any of these food groups, such as caffeine. So there's a variety of caffeinated drinks out there, you know, your lattes, your coffee, Teh Tarik, Red Bull, the energy drinks, Coca-Cola, all contain caffeine. We know that for some people, but not all people, it can really stimulate movement in the gut, what we call the gastrocolic reflex. It can trigger quite quickly a movement in the lower down in the gut, in the colon. So for some people, if that's a trigger, it can help them have a bowel movement in the morning, perhaps after their morning coffee, but too much caffeine throughout the day might then cause more frequent bowel movements than we'd like. So just being aware of caffeine as a trigger for you. And of course, in the milky teas and coffees, there's going to be lactose as well, which we'll discuss whether that might be a trigger in a minute. So what about alcohol? Alcohol can be a trigger for many people, but again, it's all about the dose. So if you find that alcohol is a trigger, just knowing what amount you can tolerate. It tends to be an irritant to for the gut. Our gut doesn't really like excessive amounts of alcohol, and it causes damage to the lining, and it can also prevent us reabsorbing the salts in our diet and the colon very well. So it can be linked with diarrhea, sort of excessive amounts of alcohol. It stops us reabsorbing the sodium and potassium, and linked with more looser bowel movements. So hence when people give up the beer, they might find they become a bit more constipated. But just noting that it's not an all or nothing thing, just finding your tolerance. And often I think when a lot more alcohol is consumed, it's maybe a bit later at night, it's maybe with a heavy greasy meal. So it might not be just one one sort of food item or the alcohol that's the trigger. It might be a combination. So meals higher in fat might also be a trigger for gut symptoms and for diarrhea. Sort of a rich, greasy, oily meal might be more likely to trigger. So it's sort of finding tolerance again, and perhaps looking for some lighter options. And maybe if you know that, you know, high fat meals are a trigger, to sort of balance, and you're going to be eating a bit of a richer meal, maybe balancing out earlier in the day with lighter meals that are a bit lower in fat, such as the suggestions, you know, perhaps instead of deep fried items, going for steamed items, more soup noodles rather than sort of rich, oily noodles, and just trying to balance it all out, including some starchy carbohydrates, some grains, some protein foods like your meat, fish, chicken, tofu, and some vegetables. So is chili a trigger for you? Chili, we know, it contains a chemical called capsaicin, which can be a trigger for some people, but again, it's all about the dose. So I know mala is very popular in Singapore at the moment. So, you know, it's just finding your tolerance. We know that, you know, if you find that you can tolerate small amounts, and that's fine. It doesn't aggravate gut symptoms or incontinence, then that's absolutely fine. It's not going to cause any damaging effects at all, but it might aggravate in large quantities. So just being aware, and it's that capsaicin, the chemical in chili, that can trigger for some people, but not all. So it's down to individual tolerance. So what about lactose? So we know that globally, around 65% of the world's population can be sensitive to lactose. But again, it's all about the dose. So lactose is the sugar that we find in cow's milk and all mammalian milks. We digest it very well when we're babies and infants, and then digestion cannot be quite as optimal as we get older. This is because when lactose is made of two separate sugars, glucose and galactose, joined together. And so they're joined together, the two molecules, and we need the enzyme lactase to help break those into the two simple sugars, glucose and galactose, for the lactose to be absorbed. If that doesn't happen, then lactose can get fermented by our gut bacteria and trigger gut symptoms such as diarrhea, nausea, bloatedness, maybe some pain as well. But again, it's all about the amount that you have. So most people who are sensitive to lactose can tolerate smaller amounts. It's not the same as a milk allergy, where we need to avoid even minute traces. It's not the same. It's important to find your level of tolerance, and just be aware that just spreading it out over the day. Most people can tolerate up to about 4 grams of lactose at a time. So if we look, I've just sort of put this chart in here just for reference, that, you know, a glass of milk would give you about 13 grams. But if you just had a splash of milk into your coffee, that's most likely to be okay. Or a few spoons of yogurt, again, most likely to be okay. Hard cheeses, butter is actually very low. And in Singapore today, there's plenty of choice of lactose-free milks. So there's, I think, Medji and Magnolia now have them on the market. There's Arla. There's a few different brands out there. They're quite easy to find. And that will have, they've added lactase to it. There's no lactose in there. So, or soya milk, if you tolerate soya milk, okay, is a good alternative. The plant milks, the other plant milks, such as nut milks and oat milk and rice milk, they can be useful, but they don't give us the same nutrition as cow's milk and soya milk, which are both great source of nutrients. So another trigger, and this can have a laxative effect in anyone in a large enough dose. So these sugars, which are actually called polyols, So looking out on the label for sugars that end in ol, they're artificial sweeteners added to sugar-free foods. So if we have a look at the Eclipse label here, you'll see sorbitol in there, quite high up on the ingredients list. And this is a sugar-free chocolate. I think I found it in the NTUC Fair Price website, and it's got mannitol and maltitol in it. So these can have a laxative effect in large amounts. They drag water into the gut and are more likely to sort of trigger diarrhea in large quantities. So having a look out for those. It's not all the artificial sweeteners though. So aspartame, for instance, is okay. That won't have the laxative effect. So just to highlight next, sort of keeping a food and symptom diary can be very useful. Taking note of what you eat each day and the quantities, the timing. We know that spacing out our food intake over the day can help, rather than having, not eating, skipping meals and then eating one enormous meal. That puts more of a strain on the gut. So spacing food out throughout the day. Noting not just what you eat, but your symptoms. There are some apps that you can find for this as well, or keeping it on your phone or in a notebook. And note the type of bowel movement that you have, perhaps, using the Bristol scale or just your own abbreviations. And when you're suffering from fecal incontinence as well, and trying to maybe keep that not forever, but perhaps, for a week or two, and just seeing if there's any patterns. I'd just like to highlight as well some foods that we could add in that we know can really help with the stool consistency. So psyllium, they've shown in some studies, can actually be quite helpful because it has excellent water holding properties. So starting off perhaps with one teaspoon, perhaps adding it either as a separate, adding it to some juice or mixing with a drink with water. It does need plenty of water to work properly, but this will help form a gel, has excellent water holding capacities, and can help improve stool consistency. So we find it's the fiber that we find in fiber gel as well, but some people find it quite convenient, say, to add psyllium husk powder to, say, their cereal in the morning, or to oats, and it can help to start with just 1 teaspoon, going up to perhaps 3 teaspoons a day, but with plenty of water. So the Origins one, I think, is available at NTUC, is quite readily available there, and some of the Unity pharmacies as well. So it's worth a try if you're looking to help improve bowel consistency. I remember a lady I saw about a year ago, and this was the only thing she changed, and she said it worked wonders. So otherwise her diet was pretty varied, but it really helped her achieve the Bristol sort of 3 or 4. So oats I'd like to encourage as well. We know they're an excellent source of soluble fiber. So a good choice, as for breakfast or a snack. I've just put an example here of sort of making some, like soaking the oats for a little while. Adding some seeds can be a great way to increase your fiber. I'd perhaps suggest flax as well. Even the ground flax seeds are going to be less of an irritant. So we know this is going to be an excellent source of soluble fiber, help with stool consistency, and help regular bowel movements. So that would be a good one to go for. It doesn't have to be blueberries that I've got there, could be any type of fruit that you enjoy, or even some dried fruit like goji berries or some raisins, a tablespoon of those as well. Or looking in the shops for granolas and mueslis and porridge, they'd all be good choices. Just getting towards the end now, but just to highlight that for some people, modifying the intake of FODMAPs can be helpful. These are fermentable sugars that we find in foods, in a wide range of foods. And they have the effect of dragging water into the small bowel, and large amounts of water. For some people, they drag water in via osmosis, and that can cause loose bowel motions for some people, because there's so much water that the colon finds it difficult to reabsorb it. The second effect is that they get fermented and gas is produced. And this is normal. It's a normal part of our digestion. It's meant to happen. It's the way the gut microbes get fed. But sometimes for some people, when they're having large amounts of FODMAPs, it can trigger this to a great extent that it aggravates gut symptoms, especially people who are also suffering with irritable bowel type symptoms. The one caveat though, I would say it is a very, very difficult diet to follow. It's a difficult diet to teach as a dietitian. And I would say if you're going to do it, really make sure that you are doing it ideally with the guidance of a dietitian. All the evidence for it helping is with the guidance of a dietitian who's trained in the FODMAP diet. The Monash website, the Monash FODMAPs website is a good resource as well. And it's not just going low FODMAPs forever. It's trying to see if reducing them helps, then reintroducing step by step, and then finding out your personal tolerance. It's not just going low and forgetting about it, because it is a very restrictive diet at the end of the day. I often see people have been on it for a year or more and are very worried about what to eat. So I'd say just being aware that FODMAPs, if you find that certain foods trigger a lot of gas, loose bowel movements, bloating as well is probably the most common symptom, then perhaps looking at FODMAPs, but ideally with professional guidance. So just to summarize, it's important to take time to enjoy your meals, chew your food properly, avoid rushing. So chewing food properly is the first part of digestion, really helping to break the food down. Being aware of the possible triggers that we talked about, and try changing one thing at a time. Don't try changing everything at once, because you're not going to know what's helping. So I definitely suggest trying to include soluble fiber more regularly, such as oats. Barley's a good one as well. Tofu's a great one, which is readily available here in Singapore, of course. Bananas and flax or chia seed, maybe the ground flax if you find that too many seeds irritate. And consider trying psyllium, because that's an easy one, and avoid letting your diet become too restrictive. So thank you for listening, everyone, and I'll hand back to Dr. Lim.
Thank you, Bridget. So a lot of information there. I was going to say digest, but that would sound like a bad pun. Yes, actually, if we look at a lot of the things Bridget said, they also share a lot of similarities with the diets that are good for health with regards to your heart, in terms of preventing diabetes or managing diabetes as well. A higher fiber diet always generally will tend to help you with bowel movement. But as she said, there are some caveats. If you find that you are having a problem maintaining your diet, even if you're following the advice and it causes you bowel problems, please speak to your dietitian, a nutritionist, or a doctor to find out whether maybe you have a condition that doesn't allow that to happen, and we can find a better solution for you. With that, I would like to now move on to the next speaker, Miss Belinda Ooi. Belinda is a senior physiotherapist at Khoo Puat Hospital, and she's going to teach us a little bit about how we can make our pelvis stronger, better with simple exercises. I hope so, Belinda.
Right, hello. Hi, let me share my screen first. All right, okay. Can you guys see my slide?
Yes.
Yes, okay. Yeah, so what Dr. Lim said, I will be teaching you some exercises and talking about how physiotherapy can help with bowel function dysfunction. So I will go through the muscles that control defecation. What is the normal muscle function? How do the muscles get weakened? Why does fecal incontinence occur? And how you can strengthen the muscles. And then I'll talk about some other treatment options we have. All right, so this is a picture of your pelvis. So there are two main groups of muscles which control your fecal continence. So the first one is the pelvic floor muscles. And the second one are the anal sphincters. So you can see, okay, the pelvic floor muscle is kind of a hammock. It goes from the pubic bone to the back of the spine. So it will support the bladder, the uterus, and the rectum. And there are 3 openings through the pelvic floor muscles to allow the urine to go through. This is the urethra, your vagina, and the rectum for bowel, for stool to go through. And if I zoom in further into the rectum, all right, okay, you can see the second group of muscles that control the defecation, and those are your anal sphincters. The internal sphincter is an involuntary muscle, so it will constantly activated to maintain closure of the rectum, and it is responsible for most of the fecal continence. And then the second one will be the external sphincters, which together with the pelvic floor muscles will do conscious maintenance of the stool, and it senses the pressure in the rectum before defecation. So when it is appropriate, the anal sphincters and your pelvic floor muscles will then relax to allow the stool to pass through. Okay, so your puborectalis is one of your pelvic floor muscles. It runs from the pubis at the front, the pubic bone at the front, and around the rectum, forming the anal-rectal angle, as you can see here with my laser. So when at rest, there is this kink which stops the stools from passing through. During defecation, the muscle, your puborectalis, will relax and increases the anal-rectal angle so that the stools can pass through more easily. And your pelvic floor muscles and external sphincters are made out of 2 types of muscle fiber. The first one are your slow twitch muscles, which support your internal organs and helps you to maintain continence when you're looking for the toilet. The second one are your fast twitch fibers. So these will resist any sudden increase in your intra-abdominal pressure, such as when you cough and when you pass gas, so to avoid incontinence during these instances. The signs of strong pelvic floor muscles would be if you have good bowel and bladder control, so no urine leakage when you're exercising, coughing, and laughing, no fecal leakage when passing gas, and being able to make it to the toilet to pass motion or urine, and having clean underwear throughout the day. You also have increased sexual pleasure, and improved muscle tone during pregnancy and childbirth. However, fecal incontinence can occur when the rectal pressure inside the rectum is higher than the anal sphincter pressure. And this occurs when there is weakening of the anal sphincter and the pelvic floor muscles. So Dr. Surendra talked about this just now, how pregnancy can increase the risk of fecal incontinence because it increases the stress at the pelvic floor muscles. This is especially if you have a heavy baby, more than 4 kg, there is increased stretch on the pelvic floor muscles, which will weaken them over time. And the second stage of labor is the active pushing phase of the pregnancy, of the labor. So that increases the strain on the pelvic floor muscle, and that can cause weakening of the pelvic floor muscles over time. And also forceps use increase the risk of damage to the muscles. Obesity, same thing, increases the strain at the pelvic floor muscles. Chronic straining, coughing, sneezing, and constipation. Over time, okay, during these activities, it increases the pressure at the abdominal pelvic cavity. So this stresses your pelvic floor muscle here below, and they will get stretched and weakened. So aging is a common cause for weakness of the pelvic floor muscles. So like what Dr. Surendra said, aging does not mean that you will get fecal incontinence. It's just one of the risk factors because your pelvic floor muscles get weaker. This is especially for women who go through menopause, and these hormone changes will cause the muscles to get weaker. Lastly, damage to nerves, such as when you have diabetes or stroke, can further weaken the pelvic floor muscles and your anal sphincters. Okay, so how do you strengthen the muscles? Firstly, you have to find the right muscles. I'll teach how to do it. And then later you have to practice your pelvic floor exercises. Okay, so firstly, okay, you can try this when you're in the toilet. When passing urine, try to stop the flow of your urine midway. Try to hold on for 3 seconds and then relax. So if you are able to stop the urine flow or slow it down, then you have identified the correct pelvic floor muscles. And that is the most difficult part of the exercise. And once you're done, you relax and finish off passing the urine. Okay, and it's very important, you only do this once as a test. If you keep doing this, you will actually may cause urinary retention, which can cause other problems down the road. So only do it as a test. Okay, now when you are with me, right, we can practice the exercise together. Okay, so I assume most people are sitting. So let's do it now when we are sitting. Okay, the first thing you do, you sit upright. You don't have to go toilet, you can just stay where you are. Okay, sit upright. Focus your attention on your pelvic floor muscles. And imagine you are stopping the urine flow by contracting, so tightening your pelvic floor muscles. So imagine just, don't need to go to the toilet, just imagine contracting your pelvic floor muscles. Okay, and then after that, release your tightened muscles slowly until you have let go of all the tension. Okay, it is important to also relax fully so that your muscles can contract again. And to give your pelvic floor muscles a full workout, there are 2 types of exercises you have to do. Okay, the first one is the slow and sustained hold. Because just now I talked about the 2 different types of muscle fibers, right? The ones that work on endurance and then the power ones. So your type 1, which are the slow and endurance muscles, to train them, you have to squeeze and lift slowly, hold for 5 to 10 seconds, as firmly as possible, and then slowly release. Okay, at the start, you may find it's difficult to hold for 5 to 10 seconds. Maybe you can only hold for 1 to 2 seconds, but that's fine. You can just keep practicing and then work up slowly until 10 seconds. Okay, and you can repeat 10 times. Secondly, you also need to do the quick and short exercises. So what this is that you squeeze and lift quickly, as firmly as possible, and then release. Okay, and then you can repeat it 10 times. So this second group of exercises will help you to maintain your urine and bowel incontinence, your bowel continence, when you are doing sudden movements, such as if you have to cough suddenly. So the 2 basic ways of doing your pelvic floor muscles are in lying and sitting. So just now we did it in sitting. If you want, you can lie down and do it also. Lastly, you can also try in standing and walking, but these is a more difficult position. So you can only do it once you are able to cope with the lying and sitting positions. Okay, remember, do not do your pelvic floor exercises while you are passing urine, because this leads to incomplete emptying of the bladder and increases the risk of urinary tract infection in the future. Build up gradually, don't overwork your muscles. Okay, remember to keep your bowels, your buttocks, your abdomen, and your thigh muscles relaxed. And avoid holding your breath. So breathe normally, because you do not want to strain or stress other parts of your body. So you can actually do it anytime you want. My recommendation at the start is to do it 3 times a day for a start, and do it every day. And then you can work it up to maybe 5 to 6 times a day. You can do it after you go to the toilet, not during. You can do it in the shower or while cleaning your teeth. You can do it as part of a warm-up or cool-down exercise. And to see progress, it may take up to 6 to 8 weeks. So you can think about when, say you're going to do strengthening at the gym, it also takes 6 to 8 weeks to become stronger. It does not such an immediate effect. And the maximum benefit may come at about 6 months. Okay, but it's okay. You don't have to wait so long just to see any full changes. You can see some signs of improvement even before you are able to fully control your bladder or bowel, such as when you see that, notice that there's a longer time between your bathroom visits to pass urine, and there are fewer accidents, or you are able to hold the contractions longer or do more repetitions when you are doing the exercises. And also cleaner underwear. So you can look for these signs to show that, to give you confidence that you are going along the right track. Okay, there are some other treatment options. So the first one, which Dr. Surendra also touched about, is biofeedback. So biofeedback is actually a neuromuscular, it's a re-education tool, which gives the patient some visual or audio feedback about whether they are performing the exercise correctly. Because sometimes some people feel it's difficult to identify the muscles. So I ask you to kind of squeeze your pelvic floor muscles. Imagine you're trying to stop the urine flow, but some people still have difficulty kind of identifying if they're doing the correct exercise. So you can come to the physio and you can do a biofeedback technique. General exercise is also good. So just cycling, walking, all these general exercises actually improves the bowel motility, so it prevents constipation. And lastly, you can look at changing your bowel and bladder habits, which I'll talk about later. So this is an example of a biofeedback. It's a real-time transabdominal ultrasound. So it's non-invasive. So if you can be familiar with the doctor or technician and assessing the fetus movement for a pregnant lady. So it will be in the same position using the same machine. Okay, so this can be used for both men and women. So the therapist can use, so if you look at the picture on the right, okay, this is a ultrasound image of the bladder, and the pelvic floor muscles are at rest. So this is the base of the bladder, okay, and the pelvic floor muscles here are at rest. But when they are activated, the pelvic floor muscles will actually rise. I mean, the base of the bladder will rise. So this gives the patient and the therapist an indicator of whether the patient is working the muscle correctly. And then once they learn how to do it in the clinic, they can go home and practice the same exercise at home. Another treatment option would be to change your bowel and bladder habits. So making sure you drink enough water throughout the day to avoid constipation. And then ensuring proper body defecation position for defecation. Okay, so we saw this photo just now, the one is sitting. So you have the anorectal angle here. When you are squatting, the angle here on the right, I mean the anorectal angle actually becomes less acute. So the stool can move through more smoothly. So this reduces the need for having to strain and push to pass motion. And over time, as we talked about just now, prolonged straining, pushing will actually weaken your pelvic floor muscles. Okay, but don't worry, you do not need to renovate your house to make sure you have a squatting toilet. You can simply put a stool under the foot, as what this picture is like. Okay, put a stool under the foot, and this will somewhat mimic your squatting position and ease the stool movement through the rectum. Okay, lastly, so if you have any issues with your exercises, please seek treatment from your doctor or physiotherapist because you may be performing the exercise wrongly and making even more problems. So just seek treatment. Thank you. Yeah, that's all. Right, thank you.
Thank you very much, Belinda. As Belinda said, we can all do this exercise at home. I've also taught my patients to do it when they are watching the television, when you are sitting at the toilet. Of course, not when you pass urine, as she said, but if you are sitting at the toilet as a chair, you can even do it lying down, and there are various methods to do it. You find one that you're comfortable with. It is important that you do it on a regular basis because then you will see the improvement usually weeks to maybe about 2 months later. And do not be discouraged if you do not notice any improvement initially. Right. And with that, I would now like to lead on to the next speaker. I believe it is Dr. Fiona Wu, who is going to share with us a little bit about a new device that can help for patients with pelvic floor exercise. Dr. Wu is a consultant urologist. She used to be working at the National University Hospital, and she's also a council member of the Singapore Urology Association. She is going to share with us now on this new device. Fiona?
Can you hear me?
Yes, we can.
Okay, hello everyone. Good morning. Thank you for coming for our clean movement part 2 today. So I'm going to speak a bit about the treatment for incontinence and pelvic floor dysfunction. Next slide, please. So basically, like my previous speakers, right, have already discussed, the pelvic floor muscle basically is a group of muscles and ligaments. So in the pelvic region, it supports the organs in the pelvis, such as the rectum, bladder, uterus, or prostate. And it plays a very essential role in continence, voiding, defecation, and sexual function. So the most common conditions we see are urinary incontinence, fecal incontinence, sexual dysfunction, and pelvic organ prolapse. So pelvic floor dysfunction, right, is quite common. It can affect up to 50% of childbearing women. Can we have next? Okay, this is a picture. I don't think, okay, because I can't have the pointer. So as you can see, right, the pelvic floor muscle actually supports all our organs. So when there's weakness, right, or some tears in it, or some injury, right, some of the organs, right, may be weakened and it might fall out a bit. I think for the females, right, what is important is the vagina and the bladder lah. So when patients come, they tell you there's a bulge, right, in the vagina, right, something, you know, must have weakened and push itself out of the vagina. So the most common one is uterus coming from the top, the bladder coming from the anterior side, and the rectum or the small intestines coming from the back and slightly from the top. Okay, can we have next, please? So what about stress incontinence? So usually these are the cases I see that demonstrates pelvic floor issues. So for stress incontinence, right, the ICS definition is a complaint of involuntary leakage on effort or exertion, on sneezing and coughing. And some patients describe they leak when they actually laugh, which actually affects them quite badly. And sometimes, right, when they suddenly squat up and down, or they start running after the bus or anything, right, they'll start leaking. So it can range from a few drops of urine, or the worst case scenario is the urine runs down the leg. So it's often a very social, psychological issues. So for the older females, right, sometimes they even stay at home. They don't go out because of fear of leakage. So it affects them quite badly. Next slide, please. So what are the risk factors? Age. As we know, right, the pelvic floor muscles weaken with advancing age, and therefore increases the risk of pelvic organ prolapse. And obesity. So sometimes we do ask patients, right, to lose some weight because it does help when they have urinary and fecal incontinence. And parity. So for parity, it means the number of children they have, and or they're pregnant for at least 20 weeks. So when they have more children, right, it's associated with pelvic organ prolapse when they deliver vaginally. And sometimes, as discussed by Dr. Surendra, right, sometimes they have very bad anal sphincter tear. So they do have fecal incontinence. And hysterectomy also. Hysterectomy occurs when the patients, right, have their womb surgically removed for various reasons. It can be benign reasons like very bad fibroid or endometriosis, which bleeds a lot. So they have to have it removed, or cancer. And without the uterus, right, there's an increased risk of prolapse. I think it's because of all the ligaments, that they took out together with the uterus. And yeah, so it actually weakens the whole system. Okay, next. So what can we do? There are lifestyle changes, as discussed by previous speakers, right? They can prevent leakage by avoiding or reducing intake of alcohol, caffeinated drink, acidic food beverages. And all these, right, it's good when the patients actually, right, know what causes their problem. So sometimes we ask them to have a food diary. For us, it's a bladder diary. It does help a bit. Exercise. Other than pelvic floor exercise, right, they should also do core exercise. because in general, when they are fitter, right, I think they can control the leakage a bit better. So importantly, right, they need to have a consultation with a pelvic floor physiotherapist. And it's not so easy to find a pelvic floor physiotherapist in Singapore. So, and the appointments, right, can be quite long in the restructured hospital. So they need to relearn how to, contract and to relax the pelvic floor muscles. I think that's important because not everyone has leakage. Some patients do have pelvic floor dysfunction and they cannot void properly. So although they tell you they don't leak, they still have problems with urination. It can be very slow. They can feel as if they cannot complete their voiding. So they go to the toilet multiple times or they sit down there for a long time. All these are issues that we need to resolve. And weight loss, as previously discussed. Next slide. Yep. So physical therapy is good. The physiotherapist will teach them how to relax and strengthen the pelvic floor. Biofeedback. This one is used by the physiotherapist. So, the patient actually learns biofeedback and they can, improve upon their already, when they're already quite good at it. Yeah, next. So what the treatment? The treatment for the worst kind of incontinence, right? When they leak with very little increase in intra-abdominal pressure, right? They need to have surgery. So, or they already tried conservative treatment and it failed. So there are many ways of doing surgery. We can try to lift up the urethra. We can bulk up the sphincter muscle through the urethra, or we can do a suspension procedure so that basically all of them improves the closure mechanism. And sometimes the gynae may be involved to correct the pelvic organ prolapse. Next, please. Okay, these are some of the picture. The picture on the top left, right, is a transobtubator method of putting in a mid-urethra sling such that the urethra gets lifted and closed off a bit so that it's tighter. The picture on the right on the top is a bulking agent. Basically, we put a scope in, we inject some a bulking agent into the spindle so that it closes better. And the last one, right, of course, is birch copper suspension. Basically, we lift up, right, the tissues near the vagina so that the whole system is lifted up. The urethra is a bit more kinked and it stops the leakage. Next, please. Then are there alternatives to pelvic floor muscle exercises? One of the alternatives, right, electromagnetic stimulation, otherwise known as HIFEM. Basically, I think it's best for patients, right, who cannot isolate their pelvic floor muscle during Kegel exercises. Despite best intention, right, some patients really cannot isolate it. And, we have to find a way, right, of doing it for them. This is especially useful for the very old patients who are not suitable for surgery or for the younger patients who don't want surgery, which I can understand. So the HIFEM works by triggering intense pelvic floor muscle contraction, and it uses electrical currents that target the neuromuscular tissue. And how it works is by modifying the muscle structure, including the growth of new muscle fibers and stimulating the creation of protein strains, strengthening it. Next, please. Okay, so one of the products of HIFEM, right, is Emsella. It's a product by BTL. So this chair has been certified by CE, which is the European body, and FDA, which is the USA body. Okay, next, please. So what are the benefits for the patient? Number one is non-invasive. You don't have to put anything inside you. The patient sits comfortably on the chair and they can, fully clothed, and it's a walk in and walk out procedure. So it's quite fast for the patient and it's easy. Come next. Okay, so as discussed just now, it uses HIFEM to cause deep pelvic floor muscle contraction. So the key effectiveness, right, is focus electromagnetic energy. It penetrates quite deep into the muscle and stimulates the entire muscle floor. And a single session itself, right, can do quite a lot of contraction, up to 12,000. So it's very important for muscle re-education for incontinent patients. Next. Yeah, this is what we discussed just now. So basically it contracts and lifts up the whole pelvic floor muscle. And so the myofibrils the muscle actually grow bigger. In other words, it grew bigger and increase in number as well, as you can see from the ultrasound picture. And next, please. These are some simple studies, right, on the safety and efficacy of this HIFEM device. So this is a study of 75 females with all sorts of incontinence, got stress, got urge incontinence, and mixed. So the number of sessions they minimally need to have is about 6 and about 2 sessions. So for 6 sessions, about 3 weeks, and they just sit on the chair 28 minutes each. So they find that on the quality of life scale, the urinary incontinence scale, right, there's a 65% average improvement at 3 months follow-up. And about 34% of patients were completely cured from their urinary incontinence. The most improvement is in the mixed urinary incontinence group, almost 70% improved. And importantly, most of them, right, have to stop using their pads altogether. And 44%, right, totally, don't have to use pads. I think that's very important because long-term use of pads, I try to discourage my patients from using pads because sometimes it does cause a lot of skin problems. They have rashes and it's very itchy. And in Singapore context, right, it's very hot. So we always try to ask them to minimize it. Give me the next slide. Okay, this is another one. Other than, this is a paper I published in Sexual Medical Journal. So basically, this is a quite good study. It's 2 intervention group. One is treated with HIFM and electrical stimulation. G3, right? There's another group called the control group. So there are two groups who are having intervention, and one group is a control group. So the outcome measure is enhancement of the pelvic floor muscle activity. Overall, right, there are 95 patients who participated in the study, and superior results was documented in the HIFM group. So all the electromyogram parameters actually improve. So when stimulated, the muscles actually work better. So it's actually more effective, right? Significantly more effective than the older type of technology, which is electrical stimulation, and in postpartum females. So I think this study, all the 95 patients were postpartum females. So it's actually, yeah. So basically by stimulating them using HIFM, right, they actually have a better outcome. Next, please. So to let everybody understand, right, for the Emsella chair, there are basically 2 protocols. One is more gentle and gradual stimulation, and the second protocol is more intense for patients who are already quite good at it. Yep. So so the first one, right, is for what I usually would use for stress, urgent incontinence, mixed incontinence, those postpartum, weak pelvic floor, those will be good for protocol 1. Protocol 2, right, are those that already know how to do Kegel. They just want to improve it because they can do like 12,000 contraction, which is, I don't think it's possible clinically to do it without the machine. Okay, next. So to conclude, right, HIFM is an alternative for females and even males, right, with pelvic floor issues or incontinence who are unable to do pelvic floor exercise, or for those who desire faster and improvement, and suitable for majority of patients except for metal implants. So yes, I think this is a good alternative for pelvic floor exercise. Yeah, that's all. Thank you everyone for your attention.
Thank you, Fiona. So as you can see, as we talk a lot today, we talk about how we can improve things through diet, through exercise, through understanding the disease, correcting our myths, and there are good surgical techniques available about bowel control. In our previous webinar about urinary incontinence, we also mentioned about different drugs, different treatments, including surgeries, and again about pelvic floor exercise and how it helped with all those problems. So this machine from Emsella is the latest in a series of improvements in healthcare that can potentially help some patients who are not suitable for other forms of treatment, and it's very low risk because it's actually 0 risk for any complications. All right, and now I would like to open the whole session to questions from all of you in the webinar. If you have anything, please type your question into the chat box and I will try to get the relevant speaker to answer your question for you. So I'm just looking through. There is a question from Catherine asking, so do we do Kegels for both urinary and fecal incontinence? Then the answer is Kegels exercise or pelvic floor exercise will help to improve both urinary and fecal incontinence because it improves your pelvic floor strength. The pelvic floor muscles actually support all your pelvic organs. So for a woman, it supports the bladder, the vagina, uterus, and the anus. For the men, it supports the prostate together with the bladder and the anus. So it can help with both. Catherine also asked, I have extremely hard stools and difficulty voiding. Other than drinking more liquids, what can I do? Maybe I will target this question to Dr. Surendra. For somebody with constipation and difficulty passing stools, what can they do? Surendra, your mic is muted.
My apologies. Yeah, thank you, Catherine, for your question. Hard stools is a very common problem. We know we have a lot of people who have hard stools, and it is a type of constipation. And before we, can treat it, we need to know what could be the possible risk factors of having hard stools, or what could be the possible reasons for having hard stools. Some of the common reasons could be lack of fiber in the diet, um, lower intake of liquids, lack of exercise, and there are some other factors like medications which are taken for other medical conditions, which are common causes of hard stools and constipation. So if we can find some of these reasons, we should eliminate them if possible. Otherwise, simple measures like exercise, increase water intake, and reducing the risk factors for hard stools could help. And when these factors do not, work, then one should get examined by a physician to see whether there is any other problems which could be responsible for the hard stools. And there are some simple tests which we can do to find out what is the type or what is the problem which is causing these hard stools. I hope I answered the question.
Thank you, Surendra. And if I could get an opinion from Bridget as well, because the truth is that nobody wants to go and see a doctor, right? So if you're at home and you have hard stools, I'm sure there's something we can do that maybe we can try through our diet to help them out.
Yeah, so, as Dr. Surendra mentioned, adequate fluid, which means for most people, minimum sort of 1,500 mils to aiming for 2,000 mils, plus being aware if you're exercising outside in Singapore, you're going to be losing a lot of extra fluid. So that means about 8 glasses, cups or mugs a day. Doesn't have to be just water, other fluids like teas and other fluids will all count as well. Making sure you're having a diversity of plant foods from your whole grains to your vegetables, fruits. Singapore recommends 2 bowls, 2 portions of fruits a day and 2 portions of vegetables a day. So really maximizing those as well. Perhaps if you're out for lunch and there's not much vegetables with your lunch, then maybe ask for extra, or get yourself, a portion of fruit to have after. So plenty of diversity of your whole grains, fruits and vegetables, nuts and seeds, but to tolerance. If you're suffering from fecal incontinence, be aware of triggers. And then possibly thinking about adding in a fiber supplement that we know isn't going to aggravate and has excellent water holding properties, such as psyllium, and maybe talking to which you can buy in the supermarkets, trying to add that, either as a supplement or to add to cereal in the morning. And other foods that have been shown to help with constipation. Kiwi fruit actually has a chemical in it that's been shown to help. So that would be worth trying as well. Flaxseed, maybe going for the ground if the whole ones that are an irritant can help as well. So flax or linseeds. And chia seeds are similar, but they're a bit more expensive. But they're sort of worth a try. Adding in some tofu, legumes to tolerance as well, beans and legumes. They can be a bit gassy, but trying those as well. That would be my sort of top tips. And oats, which I mentioned before in my talk. Oats are a great one. So that soluble fiber will improve the water, add water holding properties to your diet and improve the consistency.
Thank you very much, Bridget. As we wait for more questions, I just want to remind the audience that please stay until the end. After this question and answer session, there will be a lucky draw. There will be a set of 3 questions. The first 10 correct answers from the audience will get a prize, and we'll announce what the prize will be at the end of this Q&A. While we wait for more questions, maybe if I were to ask Belinda one question. If I'm a person who is trying to do the pelvic floor exercise at home, and I don't know how to identify the muscle, I am having trouble improving my strength and I'm still leaking urine, how do I find out how I can consult a physiotherapist so that I can learn the correct methods? Do I go through the polyclinic? Can I see the polyclinic? Will the GP know who I can see? Or must I see a specialist in a hospital for this first?
Okay, hi, thanks for the question. So I think there are, because I'm a Khoo Teck Puat physiotherapist. So in Khoo Teck Puat Hospital, we see patients who are referred from a specialist. So it could be a colorectal surgeon like Dr. Surendra, or some of the urologists that we have in the clinic. So that's how you can go if you want to see a hospital physio. Yeah, but if you want a private physio, that one I'm not sure. I suppose you have to search on, there may be some information on the Continence, the Singapore Continence Association website, or not sure about that. Yeah.
Okay. Thank you. But yes, you are quite right. The world today, as we are all on a webinar, which means we are all online, I'm sure we can all find the information online as well. I know there are private physiotherapy clinics who provide this service. You may speak to, but I think it's a good idea that if you're not very sure, speak to either your trusted family physician or any doctor first, and find out from there, and they will guide you along. So looks like so the questions are about constipation still. So someone has asked, are bananas good for constipation? Bridget, looks like it's yours to answer.
Yes, definitely. They're a good source of fiber. They include soluble fiber. I get some people thinking that they constipate, which is not, as a myth. So there's no one food that can constipate you, so yeah, I would say, but include a variety of fruits. Our digestive system really likes variety. Our gut microbes love variety, and we know that's associated with good health. So yeah, go for the bananas. Kiwis, like I said, have been shown to be helpful. Prunes as well. That sort of prune juice, but taking it easy with those because they can cause diarrhea as well. So, but yeah, bananas would be good. But there's no one food. People think eggs. Eggs is a common one that people think might constipate, but it's not just one food. It's the whole diet that will affect stool consistency.
Okay. There's a question here. Who do I see for incontinence? Do I go to a GP or do I go directly to a physiotherapist? I think I will just answer this question on behalf of the members here. If you have either urinary or bowel incontinence, the first person you should speak to will be your family physician or the polyclinic doctor. The reason is that it may not be incontinence. We want to let a doctor run through some screening questions to identify whether your problem truly is a urinary or bowel incontinence. For example, a person who has a urine tract infection may think they have urinary incontinence because they are leaking small amounts of urine. A person who has hemorrhoids prolapsing from the anus and causing some staining after bowel movement may think he has incontinence, but the problem is the hemorrhoids. So at least speak to a doctor. The doctor will help you, guide you through the process of identifying where your problem is. And if it truly is incontinence, the doctor can then make the referral to the correct specialist to see you for the subsequent investigation and treatment. So, and back to Bridget, I agree with what Bridget said about having a lot of different types of food. Our gut likes food. So a good guide is colors, to have different types of food and different colors in your food. Each color represents either a different vitamin, a mineral, or a nutrient that your body is wanting to have. So having different colors in our diet helps. Fruits are very good, but I just want to give a proviso. So not everybody can take all kinds of fruits. For example, if you have diabetes, you may not want to eat too many sweet fruits, and your doctor would have guided you on what you can and cannot take. If you have a kidney problem, there are certain fruits that are very high in potassium, such as bananas, you can't take too much of. So everything in moderation generally is good. But as Bridget has said earlier, we do recommend that everybody take 1 to 2 portions of fruit a day, 2 or 3 portions of vegetables a day. Now, on the assumption that the average person takes between 7 to 10 portions of food a day, we're talking about roughly 50% or more of your diet being made up of fruit and vegetable fiber. So try, and you will notice that when you speak to your cardiologist, he tells you the same thing for your heart. Okay, whatever is good for your bowel is good for the heart. Whatever is good for the heart is good for your bowel. All right. Yes,
Dr. Lim, because we are having questions on having good bowel movements, maybe if I can add a comment here.
Yes, please.
Yeah, we all agree that fiber is good for constipation. For most people with constipation, and this is the right thing to try first. Increase your fiber, increase your fluid, and exercise. That means move your feet. So I tell my patients, always remember 3 F's: fiber, fluid, and feet. That means move your feet. But in some certain patients, what happens, actually fiber may not help much. So that's why it's important to start with simple things first. But if they're not helping, then you need to consult a physician for it, because there are certain types of constipation where fiber can actually worsen the symptoms, like slow transit constipation, especially people who have very hard, lumpy stools, and giving more fiber to them actually may worsen the symptoms and the person may not feel good. So if simple things do not help, it's good to see a physician so that you can get a better idea about the type of constipation you have, and adjustments of the diet by nutritionists or doctors can help in a better way.
Quite right. Not all patients can tolerate a higher fiber diet, but it is something that the general public can try. However, if you find that it is not helping you within a week or two, please speak to somebody. And my one addition to what Dr. Surendra has said is that if your bowel movement is less frequent than 3 times a week, meaning you're only passing stools once or twice a week, I suggest you speak to the doctor first, because you're very likely to not benefit from a lot of added fiber. Okay, there's if your colon is that slow, then it's usually multifactorial. We will have to figure out how to help you through multiple different little changes. And I'm going to take one last question from the floor, and I'm going to direct this to Dr. Fiona Wu. It's a question from Andrea asking, should I try Emsella first or learn pelvic floor exercises? Can Emsella substitute pelvic floor exercises? Fiona?
I think everyone, right, should do pelvic floor exercise first, but you need to know whether you're doing the right thing, because I see a lot of patients, they think they know, but most of the time they're contracting the wrong muscles. When I test them, right, they're contracting the tummy muscle, the buttock muscle, the thigh muscle, all except the correct pelvic floor muscle, you see, because it's very hard for patients to understand sometimes from the description. So it's best to see one of us, right? We assess really, then we teach. Then from then, right, you decide whether you can do it yourself. If you can do it yourself, right, it's good because it's cheap, it's effective. But the moment you stop it, right, the effect is lost. That's the issue with pelvic floor exercise, I feel. Emsella is very good for patients who totally cannot isolate, because there are some patients, unfortunately, no matter how hard they try, it's very difficult for them. So I guess all these patients, Emsella will help. It's just more costly. because every time you use the MCLR chair, there is a certain cost associated with it. Pelvic floor muscle is definitely much way cheaper. And yeah, that's what I feel, especially for elderly folks in Singapore, right? I think it's very difficult for them to do Kegels.
Yes.
Yeah.
So what Dr. Fiona Wu said is correct, Andrea. To the rest of the audience, we usually want to teach you how to identify and do the exercise yourself because it is the most efficient and cheapest method. If you are unable to identify the muscles yourself, when you come to see us in the hospitals, we can guide you through the physiotherapist or through biofeedback exercise. All these are methods to help you identify the muscles. Saying that, there are patients who have very weak muscles, the elderly, or who are very frail from whatever other conditions they have. Then no matter how they try on their own, they are unable to exercise it adequately. And that's where something that can augment your exercise, such as the MCLR system, can help. All right. Ultimately, as they get better, we will then ask the patient to learn to do the exercises themselves, and that will be the long-term sustainable method. And with that, I would like to thank all of our speakers today for coming to share your knowledge and sharing with the audience. I want about all these things about bowel dysfunction. I want to thank all members of the audience for your time in listening and empowering yourself. Thank you for empowering yourself with the knowledge and for wanting to have better control for your bladder, your bowels. And please, if you find this useful, please share this information with your friends and family. If you want to find out more, you may visit our society's website. It's the Society for Continence Singapore. It's sfcs.org.sg. I am now going to hand it back to Andrea, our secretary, to talk to you about the lucky draw and conduct the poll. So there will be 10 lucky winners. These are the 3 questions. You just have to answer the 3 questions for us.
Questions? Yes.
We will leave it up for 1 minute.
Yes.
I don't think I can leave it up for 1 minute because everybody seems to get all the answers correct. I think we would have gone past the 10 winners, but we will leave the question up there. We will contact the 10 winners. Jenny, would it be, they will be giving us their information so we can contact them, am I right?
Yes, we will contact them because we have it on the back end.
Okay.
Secretarial, so you can continue with the next slide, Andrea.
Okay, and then we will just end the poll here. Okay, so this last one, well, we are a charity. So by the way, just to let you know, the entire group working for the Society for Continence, all of our secretariat, only our secretariat is paid a small, actually a very tiny, meager amount to help us do all the work. They work very hard for all of us. Every other member of the society is a volunteer. None of us are paid. We do not get any funds from the government. All the support we get comes from members of the public, as well as sponsors for events such as today. So because we are now an IPC charity, any donation made to the society will come with a 2.5 times income tax rebate. So I hope you can share generously with us. Because we only recently got our IPC, so we are using the Pay Now system for the donations. So I will just leave this up for a minute. And I would like to thank everyone once again for your time on this long weekend. Instead of everybody being in Johor Bahru, you're all here with me. So thank you all and have a wonderful weekend, everybody.